I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello, everyone, and welcome to the September edition of the PRS Journal Club podcast. I'm Sammy Sinno, your host, and joined as always by my co-resident ambassadors, Raj Sawh-Martinez and Amanda Silva. This month, we're very excited to be joined by our special guest moderator, Dr. Liza C, Associate Professor from the University of Pennsylvania Plastic Surgery Division. This article that we're going to be reviewing next is entitled The Subtleties of Success in Simultaneous Augmentation-Mastopexy by Drs. Lynn Puckett and co-authors from the University of Missouri in Columbia. In this study, the senior author looked at consecutive patients that he had performed breast aesthetic surgery on from the years 2000 to 2009. And the premise for this was to examine the evolution of his technique and comparison of overall safety and efficacy of performing augmentation mastopexy to the individual procedures alone. It's been well documented in many previous studies that there is a potential for increased and serious complications, including nipple loss and implant exposure when you potentially combine the procedures. And this risk may be additive when, again, the procedures are staged. So in looking at these patients, he isolated three arms: the isolated mastopexy, the isolated augmentation, and then again the combined procedures. He typically performed the mastopexys with a vertical pattern unless he needed to convert to a wise pattern. The augmentations were performed retropectoralis fashion, and he also outlined his combined procedure of choice, where he first marks out the nipple position, then deepithelializes the mastopexy markings and approaches the retropec space transglandularly. Then he releases the pec fibers inferiorly before undermining the skin flaps very limitedly, and then, as necessary, tailor tacks. After statistically analyzing all of the major and minor complications in the groups, he had a total of 297 patients over this 10-year period that had undergone one of these three procedures. It was noted that in the isolated mastopexy group, he didn't have enough data for significant statistical comparison. When he looked at tissue complications, these are more minor complications, he noted that they had a higher incidence in the combined group of wound separation, decreased nipple sensation, and areolar widening, and these were all statistically significant. When he looked at the sum of the data for the isolated AUG group versus the AUG-PEXY group, he noticed that there was not a statistically significant difference in complications. The discussion I thought was pretty interesting. He talks again about why a one-stage procedure may be understandable and desirable by patients due to less cost and overall anesthetic time and shorter recovery. What he pointed out was that a couple of technical nuances. He pretty much abandoned the circumareolar mastopexy due to the complications associated with that, namely areolar widening. He also points out that his data collaborates with a recent meta-analysis that was done over simultaneous augmentation-mastopexy that showed relatively reasonable overall complication rates. He does note that it would be wise to avoid this combined procedure in two groups of patients. One, those who desire a very large breast volume implant, and secondly, those that have a large areola with some modestosis, because he feels that the width of the separation of the limbs necessary to complete excision of the native areola may place the wound under too much tension and lead to breakdown. He does point some limitations of the study, namely a lack of power, but essentially concludes that consistently in his studies and some recent findings that augmentation mastopexy can be performed safely in properly selected patients. And I just want to get your thoughts on this procedure, Dr. Wu. I feel, as a resident, one of the first actual articles that I ever read was by Dr. Scott Spear called augmentation mastopexy, surgeon beware. And now I actually recently saw a paper that said surgeon embrace, published in the journal by Eric Swanson. So it seems like we have evolved into thinking that this is a procedure that can be safely performed, obviously with caution and in the right patients. But I just wanted to see what your thoughts were as you perform this procedure in your practice.
Yeah, again, what a very, very good review of a paper that talks about the augmentation mastopexy in one stage. So yes, I think when you're a resident, there are certain things that you learn and people tell you, and definitely one of them is beware of the augmentation mastopexy patient because you can get yourself in trouble. But I think this kind of procedure was introduced probably in the 1960s or 70s or so, and when it first got brought up, I think there were a lot of complications associated with it. But as you kind of alluded to, as time has gone by and patient selection is a little bit more specific, that this procedure can very safely be performed with very comparable complication rates to the staged procedure. And so yes, in my practice, I offer patients one-stage augmentation mastopexy. It's not the right procedure for everybody, but in the right person can be done very safely, and I have no issue doing it. My question for you guys is basically, I think we could probably all agree that augmentation mastopexy, it can be a safe procedure in the right patient, and that there are types of patients that would benefit from a staged procedure. But what do you think this paper has taught you beyond what you kind of already know about these procedures?
Well, I think,
what did you take away from this paper?
I think having having a senior surgeon that's done a lot of these cases basically outline, I found the discussion most useful, and particularly sort of laying out an algorithm saying, and it makes sense to kind of figure that patients that desire a very large implant volume are not good candidates, but the less obvious scenario that he points out in patients that have large areola due to the separation of the vertical limbs or Wise patterns needing to be able to excise the whole areola, that's somebody that maybe intuitively I wouldn't have thought would not be a good candidate for this procedure. So I would say that's number one. And then really I did not imagine, I thought that you could perform these procedures safely, but to really see a relatively large series that showed that there was really no statistically significant difference in revision rate, to me is a little bit surprising, because I'd always heard that this is the most commonly litigated procedure in plastic surgery. I don't know if that's still true, but the fact that somebody that's a good surgeon and a careful surgeon is able to do this relatively consistently, I think to me means that we should be thinking about doing these procedures with a little less fear than maybe we had been accustomed to being trained and taught.
Mm-hmm. Amanda, what do you think? What do you think of this paper? What is your take home from this?
So my take home was kind of what Sammy alluded to, but just that this is something that we already kind of knew, that a lot of data has already been put out there that tells us that this is safe, and everyone knows about that, Scott Steer article where, it's kind of a traditional article that everyone talks about, that, things have changed over time from that. I think that what's nice about this is that it is someone who has done this a lot and has done it over a long period of time, and he's just adding his pearls to it. So instead of just knowing, yes, you can do it, and that it's safe, knowing just the little nuances that he points out, I think is helpful.
Mm-hmm. Mm-hmm. And Raj?
Yeah, I think I agree with everything you guys are saying, and, obviously having very limited experience as a resident, the few times that we've done it, there's some interesting, issues come up. How do you, which do you do first? Do you do the implant versus do you do the mastopexy? I think that the thing that was interesting to me is that they're sort of really advocating to doing away completely with the circumareolar incision as part of the mastopexy, which I thought was interesting. I think some people would still argue that it can be a value and for scarring, et cetera. But I think the key, at least from what it's asking so far, is that it seems to be dependent truly on the size of the implant that you're going for behind that pexy. And then maybe would argue that those patients don't really need much of a pexy anyway if you're able to get away with the circumareolar. So that was sort of an interesting caveat that they're pretty strong on that, front to avoid it completely. But Amanda's right. I agree totally that I think that the pearls and the sort of subgroup management is really kind of the big value here in this paper. And then the other thing that I think we're sort of taught or to counsel patients on is that if they are going to go with a one-stage mastopexy to just really expect the possibility of having a revision down the road, to really not overpromise them that this will be one and done. And I think that the patient management part, in addition to the technical tips that are in this paper, really, to me at least, is a big value in approaching these problems of these patients.
Mm-hmm, mm-hmm. Well, I have to agree with everything that you have all said. I think you hit the salient points. I think as far as the paper, I think the strengths are the fact that it's a one surgeon, larger volume with relatively long follow-up, 15 months. That's pretty good. There are some, weaknesses to the paper. I mean, they set off basically saying that they're going to answer the question, is there a difference in complications across the three populations of patients, AUG mastopexy, AUG, and mastopexy alone? There was only 13 mastopexy alone patients, so already he wasn't able to answer that question. And then you look at the patients with augmentation alone versus mastopexy augmentation. They're pretty, they're two groups. They're good numbers, however, underpowered and probably slightly different patients as well, like the size of the implants were different. So the question is, the evidence that he is presenting, is it good evidence? So I do agree that he does have some pearls in there that you can take home and take away with you that may help you stay out of trouble in the future when you start doing these in force. But is this a paper that you're going to pull up when you're doing your research on whether or not you have a patient and you're going to offer them, augmentation mastopexy or mastopexy alone or augmentation alone or a stage procedure? Because one of the most important things that he pointed out was that you can't correctly compare augmentation mastopexy complications to patients who have just augmentation or just mastopexy, right? Because you're comparing apples, you're comparing apples and oranges. These are not equivalent things. What you have to do is you have to compare patients who have one-stage augmentation mastopexy and compare them to patients who have two-stage augmentation mastopexy.
Right.
Do you understand what I'm saying?
Mm-hmm. Right.
So, again, as you guys have mentioned, I think there's a lot of good pearls that you can take away from this paper. But as far as, the scientific question and how well it was answered, I think there leaves, some to be desired.
Definitely. Well, we can probably expect more papers and studies on this topic in the future. I think this is something that we're starting to probably overall turn the corner on, and I think more studies will probably, especially with our, addition of imaging even in these procedures. I think that's sort of another element, and also being able to look at patient satisfaction in validated fashion. I think you'll see more studies that'll look at different procedures and compare them across as we sort of go through time. So, but overall, I think you're right, Dr. Blue. A very well done study that definitely leaves more room for growth and knowledge in this area.
Yep, absolutely.
Thank you so much for a great discussion, and thank you for joining us this month.
Sure.